A very good morning to all of you. Welcome to the CPD webinar series organized by Society for Health Research and Innovation. First, I would like to introduce you with the housekeeping rules. The webinar link will be available from 9 a.m. to 9:50 a.m. due to join in. No late attendees will be entertained thereafter. Each attendee should have been attended till the end of the webinar to obtain the certificate for CPD points, and the CPD points are strictly adhered to the NCCPD guidelines. Thank you in advance for your strict adherence and kind compliance. You can ask questions at the end of the webinar and you can type them in the chat box. And if you have very specific questions, you can email us on office313@gmail.com. So today's topic is Common Pediatric Surgical Emergencies, Identification and Management, Part 1. The guest speaker for today is Dr. Balasubramaniam Sayanthan, Consultant Pediatric Surgeon and Lecturer at the University of Jaffna. He completed his MBBS in University of Jaffna, MD in University of Colombo, and MRCS Glasgow with a fellowship in pediatric surgery in New Zealand. He is specialized in pediatric surgical emergencies and trauma management with over a decade of clinical and academic experience. Over to you, Dr. Sayanthan.
Thank you very much. Thank you for your kind introduction. Very good morning for all of you. So today, I want to give some basic idea about some pediatric surgical emergencies. This is common topic for every doctors, even ordinary doctors or some specialized doctors. Everyone should know about this. Whoever having kids at home also should have idea about these topics, because these are emergencies. Anytime it can occur among the kids. So that's why I chose this common topic. This is example in the few medical students also should know about in and out on these topics. You can easily identify the heading appendicitis in children. So this is one of the commonest emergency. So there are many emergencies can occur in kids. This is, you can see commonly they will present with abdominal pain. So we will go one by one. Especially appendicitis is a common topic. Everyone knows about appendicitis, but here we need to focus a little bit more on this topic, because there are some similarities as well as variations between adult patients as well as pediatric patients. So here I especially mentioning the things related with the pediatric society. So definition point of view, we know appendicitis is an inflammation of the appendix, especially occurs in the children. Important of this topic because it's a common surgical emergency. Then it's one of the leading cause for abdominal pain in children. There are several other causes possible for abdominal pain, but this is one of the important as well as critical condition. So if we take in our part, sometimes even minor constipations or some other limb knot enlargement like mesenteric lymphadenitis can cause this abdominal pain. But if we miss the appendicitis, that outcome will be very worse. So that's why we need to mainly focus this appendicitis and exclude in early stage. Everyone can have a lifetime risk of 8%. That is a considerable large number. So anyone can get appendicitis in their life. That risk is 8%. So if we miss the early diagnosis, especially in pediatric population, they will end up in major complication like perforation, peritonitis, sometimes long-term complication like adhesions and recurrent abdominal pain. So we may need to focus the patients as early as possible, and we need to do the needs. So there are some questions. You may already attend this question, but just want to know, because appendix can occur any age group, but commonly if you take 11 to 20 years, that's a common. Many patients you can see in between this age. That's a transient age. That patients will come to pediatric group as well as in the adult group also. But if you take this category, you may get many patients in 10, 11, 12, that's sort of range. So you may encounter a lot of pediatric school kids with this sort of pain. So basically, just we can see this picture. This is very illustrative and easily understandable picture. You can easily see this is the normal anatomy of the cecum, appendix, and ileum. So if you notice, there is some obstruction due to some particles that may be called fecolids, sometimes calculi, sometimes lymphatic hyperplasia. Anything can obstruct this lumen. Because appendix is having a narrow lumen, it should be empty. This also having peristalsis movement, it will empty the lumen on and off. So in these conditions, suppose some obstruction happen in this lumen, automatically this passage will block. So the secretions will accumulate in this area. Appendix contains a lot of mucous glands, so it will secrete a lot of mucus. Everything will accumulate here. So without proper drainage, this particular part of the area, the obstructed mucus get infection and overgrowth of the bacteria. So you can see here, second picture, you can see intraluminal pressure of the appendix going up. So due to that, automatically, due to that, the pressure effects of this increase intraluminal pressure, it will indirectly cause ischemia to the mucosa in early stage and necrosis, and gradually it will increase the backward pressure towards the venous system, arterial system. Finally, this appendicular artery will get thrombus. So total appendix will get ischemia. So due to ischemia and infection, this will rupture because accumulation of the materials will be more and more, and it will give more and more pressure, and finally it will rupture. After this early stage of appendicitis, if we not treat properly, if we not involve properly, it will blast, it will rupture. So it will release the pus surrounding the area. Our natural body mechanism, this surrounding area will be covered by the small intestine, omentum, and other structures. So it will try to seal the spread of abscess. So finally, it will make a walled abscess or sealed abscess. That's the natural progress of the appendicitis. But our target, we may need to intervene as early as possible. Suppose if patients comes in this stage, that's fine. But most of the time, we will see the patient in this stage. So without delay, we need to immediately intervene, and we need to release that means remove the appendix by the surgical method. And we will discuss, there are a lot of controversy, lot of debates, and we will go through that one by one. So we know now appendix, if we not treat it properly, that will get perforation and development of abscess will happen. So very rarely it can resolve spontaneously, but usually it will recur, relapse, and chronic appendicitis possible. But if you take the history, approximately 82% of the children younger than 5 years will get perforation. That means if we are not intervening in the second stage, these 82 people out of 100 will get perforation. But if we take younger kids less than 1 year, you may ask, 1-year-old kid can get appendicitis. Yes, definitely. But the numbers are less than other kids. But if we take 1-year-old kid, usually we may not think about appendix immediately, but when we do the surgical time, almost all 100% of the people, babies will have perforation. So we may need to think any age it can happen. Even 1-year-old kid can get appendicitis. But the numbers are less compared to school kids. Another small question for you. Already you have attended this question. You see, there are so many signs and symptoms possible with appendicitis. We will discuss one by one. But you see, all the signs are almost possible with appendicitis. But this question is mainly asking which one is initial signs. So, appendicitis patient can vomit, pelvic appendix, they can have diarrhea, periumbilical pain is a commonest sign, and rectal bleeding possible sometime with vascular involvement, and right iliac fossa pain also one of the common thing. But our question mainly asking, what is the initial symptoms of appendicitis? Initial symptoms, that answer is periumbilical pain. Following that, they will vomit one or twice. Then that pain will shift to the right iliac fossa and pelvic appendix with inflammation or abscess. They may have sometime diarrhea, sometimes urinary symptoms. So that all are possible with this question. But answer is the initial symptom, that is periumbilical pain. So diagnostic challenges. Why we want to feel difficult to diagnose? Because you see the classical periumbilical pain migrating to right iliac fossa combined with nausea and anorexia will found only 50% of the patient. So other 50% will present with different signs and symptoms. I will show you in the following slides. And you see the classical, we are expecting classically, especially when we were in the medical student time, we always thought like that, no? First periumbilical pain will come, after a certain time, it will shift to the right iliac fossa. You know the anatomical nerve supply, that's why I didn't go deeper. So it will shift to the right iliac fossa. Then persistent pain will be in the right iliac fossa associated with nausea and anorexia. So these are the classical signs only present in 50% of the patient. Other balanced 50% will present with different manner. We'll go one by one. And always our diagnosis in order, like history, examination, laboratory findings. So history, will be just vague abdominal central pain will be starting point. Then it will gradually produce one or two episodes of vomiting, and patient may have anorexia, mild grade pyrexia possible. Pyrexia means fever, mild grade temperature possible. After that, this pain will shift to the right iliac fossa. That means this will disappear from the periumbilical region and it will present in the right iliac fossa. Then patients getting more and more tenderness and more lethargy, feverish. If we not attend immediately, the patient may have some more sick, that means more sick, more fever possible, abscess formation possible. Depending on that, their progress will be varying. So then our next step, we will investigate, we will manage, we will go one by one. So there are 755 patients, that means children present with abdominal pain, and that author found that research only 50% presented without pain migration. 50% without 50% presented without pain migration, another 50% without rebound tenderness, 40% without anorexia, 29% without nausea. So you see the variations of the presentations are there. So don't ignore the abdominal pain. If patients with abdominal pain, don't expect always they will present with classical signs and symptoms. According to the books, everything is fine, but real patients are not like that. They will have various signs and symptoms. So don't ignore, properly do examination. Any doubt, better to consult the pediatric surgical team. We know the anatomy of the appendix location. So commonly that is located in the McBurney's point. So you see what is a typical pain typically associated with appendicitis. So there are signs and symptoms are different, but McBurney's point tenderness is the commonest thing we need to find with the appendicitis. So your answer may be McBurney's point tenderness. You know the location, that is from the anterior superior iliac spine to umbilicus. If you draw a line between anterior superior iliac spine to umbilicus, So 1/3 from the anterior superior iliac spine. So that is the location, the base of the appendix will be there. So if they have tenderness, we may need to give a chance to think about appendicitis. That is important. As far we know, every abdominal pain, we will think about appendicitis and we will order the blood counts. But that is not very sensitive or specific for the appendicitis, because this blood count, usually we will request full blood count or complete blood count, especially we are checking for WBC count, white blood cells. So absolute neutrophil count will be sometime we are checking, C-reactive protein we are checking. But these sort of common inflammatory markers can rise in various medical conditions, including urinary tract infection or any other abdominal pathology. It can rise. So this is not very sensitive or specific, but it will give some idea about the this progress. So we may need to clinically correlate with the blood investigation findings. You see mild elevation, 11 to 16,000 is most common scenario. So if you see the patients in the first day or second day, most of the time they may have mild elevation of the in WBC count. But marked elevation suggests perforation or another diagnosis like pyelonephritis. So always think about the mild elevation. Even appendicitis patient, they may have mild elevation or even normal blood count possible with appendicitis. You see, normal blood count will not exclude the appendicitis. There are various score system because for easy and early practical career, sometimes doctors may prefer to use the scoring system. So there are scores: Alvarado score, pediatric appendicitis score, that's mean PAS score. So, and another score is there, AR score. So there are various scoring system. Almost all are based on the clinical examination, presentation, as well as blood investigations. But pediatric appendix score is very simple. You can easily see, I will show now. This is a PAS score. You can see anorexia, they will give 1 marks. Pyrexia, mean fever, 1 marks. Even mild temperature elevation, we need to give 1 marks. Nausea, vomiting, again 1 marks. Migration of pain, 1. Rise bloods, WBC, 1. Rise neutrophil, again 1. RF tenderness, 2 marks. Cough, percussion tenderness, hopping tenderness, 2. So hopping sign is easy way. We can ask the child to jump. If they're a big child, they will jump. When they land in the ground, they will feel the pain in the right iliac fossa. So that is easily you can find. And coughing time also, because of peritoneal irritation, they will have pain. So this score, more than 5, you can think about appendicitis. If it less than 5, less likely appendicitis. But even 100% you cannot exclude, but less than 5, you may think yes, less possibilities of appendicitis. If you have any doubt, don't ignore the patients. Next day also review the patient and assess again. There's safety for patient as well as you. So another issues with the scoring system, less reliable in adolescent female, because female patients, they may have other pathologies like ovarian pathologies can mimic this sort of pain, and sometimes pelvic inflammation or other conditions related with the gynae. So they may have this problem. So the scoring system itself not enough to diagnostic tool, but we need to get some other modalities of supporting evidence. Especially we are believing the imaging studies. So, commonly we are using 3 types of imagings in Sri Lanka, mainly ultrasound scan, now almost freely available in many hospitals, but there are some limitations. You see advantages and disadvantages of both the all three investigations. You see here ultrasound rapid bedside modality. So we can easily do that with well cooperation with the patients. Most of the time the kids will cooperate because it's a non-invasive procedure and user friendly, so usually they will cooperate. And some kids may need sedation because if they are very anxious for the machineries or something. Otherwise almost 99% they will cooperate with mom. So but one disadvantage, it's operator dependent, and sometime off time it will be not available. And sometime bowel shadows and other things may give some obscure of the field. So that time they may have difficult to identify the appendix. CT, usually it will reserve for complicated appendix in our part of the world. Usually because it's expensive and high radiation, and availability is less compared to ultrasound, and it will be costly also. So it will usually reserve for complicated appendicitis. If we think this child is having a big abscess or some other different pathology, we may need to do CT scan to exclude the diagnosis. So include find the diagnosis. MRI very rarely we can use because sometimes post-surgically we may need to get some more anatomical idea, sometimes recurrent abdominal abscess, and we don't know the exactly pathology about pelvis. We may need to do this thing. MRI is sensitive wise very good, but it's costly as well as it will in some kids needs general anesthesia because it will give noise. So the kids will not like MRI sometimes. But very big kids, maybe teenagers, they will understand, they can cooperate without anesthesia. So CT also similar. Small kids, they may need to do sedation under. So these are the common investigations we are using. Commonly, we will expect ultrasound scan. Ultrasound is a fairly good investigation. Imaging point of view, we can find the appendix. There are so many differential diagnoses for the appendicitis, but we need to exclude one by one during our investigation as well as examination. And finally, we can think about the appendicitis, but everything should happen as early as possible or as quick as possible. Mesenteric adenitis, Crohn's disease, mycal diverticulum, cecal diverticulitis, viral gastroenteritis, bacterial enteritis, cholecystitis. Even sometimes right iliac fossa pain, patient will not have right iliac fossa pain because appendix will be in the higher position, close to the right hypochondrium. So we have operated many patients in similar presentations. Sometimes we will confuse this maybe cholecystitis or appendicitis. So we need to finally confirm with the surgical management. GI tract infections. Already we discussed urethral calculi, ovarian torsion, ruptured ovarian cyst, salpingitis. Even testicular torsion can present with right side abdominal pain. So that's why all the right abdominal pain, we will examine the scrotum in boys. So otherwise, sometimes we may miss testicular torsion and we will try to find the appendix. Appendix may be normal, but finally we will miss the torsion. So there are so many debates going on. One is perforated appendix and non-perforated appendix. So that means non-perforated appendix and perforated appendix. Third one is the perforated appendix with well-formed abscess. So they will ask, even parents will come and ask, and our colleagues will ask how you are going to manage this patient. Because even everyone still wants to do management without surgical treatment because everyone scared to surgery. So that is a human nature. So their first question, shall we give antibiotic and treat the appendix? Or they will ask, suppose if we treat with antibiotic, what are the future complications possible? Any possibilities of recurrence? So how it will be end up? So many questions we will encounter day by day. So similar doubts you also may have in your mind. So I will explain. If you have any special questions, you can inbox me also. So you see this one. First, we will think about a non-perforated appendicitis. That's mean very early stage of appendicitis, and how will we manage? Then perforated appendicitis. Third one, perforation with well-formed abscess. Right. So first question, in common question expected from all the parents: appendicectomy necessary or not? Shall we manage non-operative management method? That means antibiotics. In ancient days, that was one of the method of management routinely. Because surgery give more complication, more death rates because of poor anesthesia technique in the old system, and poor surgical equipments, poor sterility. Lot of things were there in the past, but nowadays all are very advanced in the system. So we don't want to bother too much about the surgical management at this point. So I will come with some data. So second question here, you see there's a early versus delayed appendicectomies. Third one is a laparoscopic versus open appendicectomies. So there are three things we need to see. So if you take this question, first one, appendicectomy versus non-operative management. Appendicectomy considered standard treatments in this world. So there is no more question on that, because if we find clinically appendicitis, if parents are happy to go ahead with surgery, child is having not much comorbidities, they are fit child, we usually consider appendicectomy, because this is a one shot work. So after that, most of the time they will not have any problem with that particular appendix. But sometime still we have some parents may anxious for surgery. They may have past bad experience with the surgeries, and they will kindly request us to avoid the surgery. So that sort of things, we may think other options, non-operative management. So how we are doing non-operative management? So non-operative management, usually we will start with good antibiotic and rest, and we will clinically observe the patient for certain days, and we will discharge. Then when we are discharging, again we are giving two options, because sometimes this appendix can recur. That means again that kid can get appendicitis. You see approximately 90% of the appendix will cure. That means if we start to treat 100 patients non-operative management, 90% will cure in the first instant. Another 10% needs surgery, because they will go in a bad direction. This 90% will go in a good direction. They will end up in success at that point. But that another balance 10% will go in a bad direction. They have developed abscess, they have developed fever, they will not cure. So we need to intervene that 10% of the patient. That's the first thing you need to notice. Second thing, even though we cured and send the patient back to home, about 70% of the patient will be okay. Another 30%, they may get another second appendicitis. That may be differ from country to country and our treatment regime, but approximately you think another 30% may get second appendicitis features in 1 year time. So you need to tell the parents that, because appendix is still inside the abdomen, we never remove that because of the parents' anxiety or something. So we need to clearly tell them, if they are not completely taken out, it may recur again. That possibilities are there. 70% of them are good. Another 30% they will get appendicitis. So they may need to come second time to the hospital. And compared to appendicectomy patients, and as well as appendicitis patients as well as non-operative management patients. Non-operative management patients needs longer hospital stay. So that is one important things you need to know. So suppose you see appendicitis patient will go home in 3 days. This non-operative management patient may take longer hospital day, maybe 5 days, 7 days, depending on the progress. And if we leave the appendix, there are very rare chances of malignancy from that particular appendix. So that may be 0.6%. And then you see there are some reasons we straightforward go to the appendicectomy, because we cannot keep the patient for non-operative management, because obviously we found appendico leak in the ultrasound scan or CT scan. We may need to do the surgery, because we know that is giving trouble. Definitely it will perforate and give more trouble. So we don't want to take risk on that patients. We need to clearly tell the parents, even though they insist to manage non-operatively. And abdominal pain more than 48 hours, that's mean almost that chances of perforation is high. So that sort of patient, we don't want to waste the time and give antibiotics and manage them by conservative management. So, and very high blood WBC count and CRP also high, more than 4, and signs of abscess. These sort of patients, we don't want to take risk. We cannot offer the non-operative management. I will give some other special example for late presentation. That is a different story. This is intermediate patients. You always think about surgical management. But if they present first day, sometimes we can think about medical management, but that also not much recommended. So another thing is there. Sometimes parents and doctors will insist to do the surgery then and there, even midnight appendicectomies. Midnight appendicectomies are popular in early days, not now, because now we have a good antibiotics. So if suppose patients presented to you around 8 p.m., don't rush to do the surgery in the midnight. Some surgeons still they prefer to do then and there in the midnight. They will call the anesthetist, they will get down all other team and do the surgery in the midnight. But the studies shows give proper antibiotics and wait until morning. Only few hours you are going to wait. That will not much alter your outcome of the patient. So that is an important thing you need to know. So midnight appendicectomies are no longer recommended. That is an important thing you need to know. So because you are starting the good antibiotics and preparing the patient, resuscitating a patient, that is important. You need to wait until morning and do the surgery in the first case. You can wait 10 to 12 hours or 24 hours with good antibiotics, and it will not much affect your outcome and complications. You know, laparoscopy versus open appendicectomies. Everyone prefer laparoscopy. This is a very nice system. So we are using laparoscopy for many surgeries, not like appendicitis. From day one baby onwards, we are using laparoscopies. So very easy and very user friendly, and we can do the surgical management equal to open surgery through the laparoscopy. There are a lot of advantages, and previously we had thought appendicular abscess formation, that means post-surgical abscess formations rates are higher in laparoscopy than open surgery. But recent studies says that is not true. That means post-operative abscess formation is equal to open surgeries. There's no more excessive abscess formation in the laparoscopy. That is a good news for the laparoscopy surgeons. So second thing, there are so many benefits. You can see laparoscopy will reduce the wound infection. Usually appendicular wound will get infected during open surgeries. contamination. So they will get wound infection. So surgery will be success, but following that, they may have wound infection. That's the one thing. Second thing, postoperatively, small bowel obstructions are less in laparoscopy appendectomies. And particularly easy in obese patient. Even though now kids, they are getting obese. Sometimes some kids, we are operating more than 100 kilogram kids in 12 years old. So that sort of patients, open surgeries are very difficult, but laparoscopy is very convenient for them. But depending on the surgeon's experience, this conversion rates are very minimal, because very senior surgeons with experience, they can manage all the complicated appendix with laparoscopy. They don't want to convert to open. But if they feel any difficulties, they will convert to open surgeries, because that for the safety of the patient. Again, you may have some questions because some new techniques are there in the laparoscopy. Single port appendicectomy or three-port appendicectomies. Conventionally, we are using three-port appendicectomies. That means one umbilical port. That's usually one umbilical port and two more other ports. So that two more ports are called as working port. So there are three tiny incisions in the abdomen, you can see. But single port technique, they will put a one big port in the umbilical region. Through that, all the equipments, they will pass and they will do the surgery. That is means single incision laparoscopy appendicectomy. So according to statistics, I will show you. So any benefit between both techniques? So nothing much difference. But the single port take 5 minutes longer time than multi-ports. Surgical site infection, analgesia dose, length of stay, time, everything almost similar. So there are no more advantage over one technique. So you can practice whatever you want. But cosmetically also, the 6 weeks time, single port, you will see only scar in the umbilical region, but three ports, you will see another two tiny scar in the other regions. But after 18 months, all the scar will disappear almost. So after that, cosmetically, all are same. So nothing much different. So again, we already talked about perforation, the terminology of perforation. What do you mean perforation? What is that? So perforation means identifiable hole in the appendix during the surgical procedure, or sometimes fecolids in the abdomen possible. So this obviously fecolids or stool in the abdomen, obviously this is perforation. That means macroscopic perforation. So these sort of patients, we may need to have some more close observation and management, because they may have post-surgical complications like abscess formation, intestinal obstruction, and peritonitis. Some thoughts are there. Even if the patients presented in a delayed presentation, more than 5 days delay, how we need to manage these patients? Shall we do same operation? Shall we do same type of management? Still that debates are going on. Most of the surgeons nowadays prefer conservative management for this sort of patient. Conservative management including antibiotics, sometimes aspiration of the pus. So again, the aspiration of the pus, we can do in a various method. One is open method. We can cut the tummy and we can aspirate, and limited irrigation, we will come out. Or otherwise, we can do percutaneous aspiration with the image guidance. Like we have good ultrasonographers, so radiologists, we can get their support and we can do the aspiration with the guide of ultrasound scan or CT scan. After that, we need to sometimes place the tail as a pigtail, some small drainage tube. So I will come with one slide. So already we have discussed about the antibiotic treatment. Usually delayed appendicectomy, we will give antibiotic for uh, mm, at least 2 weeks, and we will do the appendicectomy after 6 to 8 weeks, because you see this is a late presentation. They may have sometimes massive adhesions around the RF region. So better to don't jump and do the surgery then and there, because it's sometimes that will be very difficult and give more damage to the patient. So we need to give antibiotic and wait for certain time, minimum 6 to 8 weeks, and later we can do the interval appendicectomy. That is a routine procedure still. But in early stages of abscess, we can try to do the surgery. But if it more than 5 days, better to avoid and wait for completely heal that area. Later we can go and do interval appendicectomy. So there's another trial. That's an interesting trial. 64 patients initial appendectomy group, second one 67% interval appendicectomy, but nothing much different. Almost all the groups are outcome same. So depending on the operator's preference, they can decide. Already we discussed some conditions, they will not succeed with non-operative management, so they need to go with surgery. Already we discussed that part. So again, we talk about the surgical drainage and percutaneous aspiration. So nowadays, percutaneous aspirations are benefit because we less trauma to the patients. But suppose that will always not succeed in some patients. So sometimes we may need to go surgical drainage also. Right. So finally, the main point is always early operation, early diagnosis best than all other things. So antibiotics also, if we decide to do surgery, then and there we need to start the antibiotics. Don't wait for start the initial antibiotics. Early appendicectomy is better. So early appendicectomy in early stage is always better. This some randomized trial and some basic ideas about this is a summary of this your presentation. I have earlier mentioned something. So we can observe and keep monitor, but there are chances of recurrence. So always better to go surgical management as early as possible. If suppose late presentation, we may think about other conditions, other management options like antibiotic and conservative and interval appendicectomies. So already we have discussed about surgical drainage and percutaneous aspiration. Percutaneous aspiration now important part of current practice. That's important we discussed, and we'll see. Complications are important. You just have a look on complications: postoperative intra-abdominal abscess, postoperative intestinal obstruction, stump appendicitis, nerve entrapment, development of right inguinal hernia, subsequent fertility issues in female, inflammatory bowel disease. So the exam point of view and your interest, I will give some shares slides. You just have a look. Abscess formation, this is incident is 3.4 to 3.8%. So this is not much different between open and laparoscopy surgeries. That's one of the common complication, intra-abdominal abscess. This is more in Western world than in Sri Lanka, but Sri Lanka also we have seen several kids with intra-abdominal abscess following surgeries. Retained fecal, it's one of the possibility for abscess formation. Again, postoperatively, we expect the patient will get improvement in 1 or 2 days. But if not, we need to always suspect this part also. Diagnosis, again, I said ultrasound helpful or CT scan may necessary to diagnose. Intestinal obstruction, this is not very common, very rare, but it's also possible. Because especially this is possible after perforated appendicectomies, appendicitis. That means perforated appendicitis, they may have pus and adhesions due to inflammation of the peritoneum. So this is one of the another complications. Stump appendicitis, that is very rare, not a common thing, but sometimes some difficult cases, sometimes surgeon may miss the stump. If it more than 3 centimeter, sorry, there's some even study says more than 3 centimeters, some stumps 0.8 centimeter, but even though they are getting stump appendicitis. Nerve entrapment during mainly it will happen during open surgery. So open surgical time, we may sometimes damage some nerves, especially ilioinguinal nerve, iliohypogastric nerve. This may be damaged or it may be trapped with sutures. So following surgery, the patient may have torrential pain. They may have severe pain following surgeries because of entrapment of the nerve. Usually we can manage with neuromodulator, some medications and sometimes nerve blocks. Very rarely necessary for neurectomy, surgical neurectomy. Inguinal hernia. You see, again, when we damage the nerves unexpectedly, it may cause weakness in the muscles. So there are some theory, maybe right side inguinal hernia occurs with appendicectomy patients, especially open appendicectomy, not laparoscopy, open appendicectomy patients. Fertility issues, because you see sometimes appendix may cause ruptured appendix and abscess formation. It will attach the ovaries as well as right side fallopian tubes. Due to blockage and damage of the right side tube, there may be thought of some possibilities of subfertility in future, but not proven. So this is still in a theory. But other reasons also possible. That particular patient may have pelvic inflammatory disease and other things also possible. And inflammatory bowel disease, you may know sometime the MCQs in exams, they will ask sometime. If you do appendicectomy under age of 50 years, low risk of subsequent ulcerative colitis. And same time, it will increase the risk of Crohn's disease. So it will reduce the risk of ulcerative colitis and it will increase the risk of Crohn's disease. So this is one thing you need to know. Missed appendicitis. So this is the highly risky thing for many doctors. So we will never miss the appendix. This is one important things you need to know, especially school children. You may think other disease, other diagnosis, but don't miss the appendix. This is under the important thing we have discussed appendix, but we will go through the other two short headings. That is for your interest. After that, we'll come to the question sessions. This is one simple thing you need to know, but this is an important thing. That's why I want to touch you. This is the interception, telescoping of the bowel from, you see, distal limb is in this area. This is a proximal limb. This is a telescoping things happening. This is called interception. Commonly, it will happen in the ileocecal region. So, important thing you need to know, I will just tell. This may occur between 2 months to 2 years of age, but commonly it will happen within, suppose 6 months to 12 months, maybe 1 year time. But it can happen in various books, says various things. Even 3 years, 5 years, 10 years, or even adults, they can have interception. But the ratio commonly happen in the younger kids. Most commonly idiopathic. We don't know the reason. But pathological lead points may be possible in some big kids. You can see this is the distal limb, this is a proximal limb. So this is telescoping inside. So this is, you just have a look. The baby is crying due to severe pain because it's a severe colicky pain. Again, male to female ratio is common. Rotavirus infection, vaccination may aggravate this interception. So age may be vary, 3 to 3 years common, but 6 to 12 months the peak incidence. These are some lead points. Lead points mean this may have some abnormalities in the bowel anatomy that will help to facilitate this interception. Micelles diverticulum, duplication cyst, lymphoma, intramural hematoma, recent interception reduction. You see after reduction also 5 to 15% they may have interception. Recent bowel surgeries. Commonly it will happen ileocecal region. So all other part also possible, but commonly happen in the ileocecal region. Even some, you see 3-month-old had interception due to Micelles diverticulum. So various reasons are possible. History, again, intermittent pain, distress, and increased frequency of This sort of cry will go in the next 12 to 24 hours. After that, patient may have sometimes persistent pain due to ischemia. So baby may have lethargy and tired, vomit, and sometimes they will scream, and between that they will feel tired and they will sleep. So diarrhea preceding these complications possible, because diarrhea also one of the precipitating factor for the interception. Red currant jelly stool is a late presentation. Don't wait until the red currant jelly stool. That is a late presentation. So abdominal distension may possible, not always, but possible. Ultrasound is a good investigation. You can find more than 98% sensitivity as well as specificity. After that, we can get the management. X-ray abdomen also possible. You can do, but ultrasound is more than enough for diagnosis. X-ray also you can find some signs: target sign, crescent sign, absence of leakage sign, bowel obstruction features. All these things possible. But ultrasound is superior investigation you can do. Very rarely you may need to do CT scan, but always avoid that. Contrast enema is important. Contrast enema will help to treat the condition also, but if not available, you can do other methods of treatment. I will just say how to do the treatment. Non-surgical management, air enema or saline enema. This telescoping transient obstruction will be there. So you are going to push the saline from the bottom or air from the bottom. That means through the anus. So it will go and release the obstruction. That's a simple mechanism. But there are success rates, suppose sometimes failure rates also. If they fail, we need to do surgical reduction. So always better to do it in a proper surgical center and with the cover up of pediatric surgeon, because sometimes this will cause bowel perforation. So don't take risk and do the surgical, this sort of, even though non-surgical procedure, this one is important, do it in a proper way in the hospital. After that, patient will be cured quickly, but 5 to 10% of recurrence are possible. You need to clearly instruct the patients. Suppose that's failed, some centers they will practice contrast enema, because two benefits: contrast will push the intestine, release the intestinal obstruction, as well as clearly visualize through the fluoroscopy. If that also failed, we can go for surgical management. Surgical management, you can see there are some reasons: non-surgical reduction failure, signs of peritonitis and perforation, shock or severely ill child, prolonged symptoms more than 48 hours, pathological lead points, and recurrent interception. We need to think about pathological lead points also. So that patients, we need to go with surgical reduction. Surgery also, laparoscopically we can do, open surgically we can do. Two things we can do. Again, one question I have given to you earlier. This is a stable patient with interception. How will you manage? What's the first line treatment? I am just asking treatment. So here, we don't want to do open surgical reduction. Antibiotic not necessary for, unless perforation. Otherwise, we don't want to give antibiotics. Fluid resuscitation important, but that is not a treatment. That is a resuscitation part only. Air enema is the answer, because they want to try with the air enema first. Laparoscopic surgery is a late treatment. So first line treatment, mainly this answer focus on air enema. Another little bit topic, if time permits, I can touch. Otherwise, I think this time is not enough to cover up that particular part, because we have covered two important part. I think we'll give time for the questions. What do you think about that? Shall we wait for question sessions? Because this is another topic. If I take, it will take another 15 minutes. We will stop and we will wait for questions. Any questions? If you have, please ask me. Thank you.
Yes, Dr. Sayanthan, we'll go with the questions. There are several questions in the chat box. So
Yes.
first question is, how long usually take symptoms appear to rupture?
Yes, a good question, because according to patient's age and comorbidities and other bacterial virulency of the bacteria, that means highly virulent bacteria or not, that symptoms will quickly start. Suppose 1 year babies, within first day, second day, they may have ruptured and they will present with abscess. But little aged kid, maybe 10-year-old kid, 15-year-old kid, they may present second day, third day onwards only abscess, because of their uh, age as well as other comorbidities and immunity. Everything will decide the abscess formation. So there's a no clear-cut idea, but usually second day we will think, second day or later we will think that chances of abscess formations are high. Any question? Next question, please.
Next question is, perforation of appendix, is it an absolute indicate for open appendicectomy?
Yes, good. But perforation of appendix depending on the duration, because you see first day, second day, third day, sometimes perforation occurs depending on the patient's age. Even early perforation, maybe second day, third day, better to go ahead with the surgery. Don't wait. Suppose the patient presented to you after 5 days, even though perforation, even though abscess formation, we are giving option for conservative management, because that time the appendicular abscess sealed well with adjacent structures. So that particular area highly inflamed due to inflammation and infection. That time we don't want to go and try to prick the abscess or open the abscess and do the surgery. That will give more chances of damage than benefit for the patients. So late presentation of the abscess, we will manage conservatively. Early presentation of perforation, like mean just today or today only just perforated and mild soft abscess, that means soft mass. So we can offer the surgery. So now I think you will be clear. Very late presentation, even though abscess and perforation, we are managing conservatively. Up to third day, fourth day, we can operate without much damage for the patients. That will give quick recover for the patients also. I hope you will understand that one.
Yes. Then another question regarding the perforated appendix, is laparoscopic appendicectomy contraindicated in perforated appendix?
No, not at all. Because laparoscopy almost equal to open appendicectomies, unless very massive abscess and we may need to do some surgical procedure additionally than appendicectomy through that particular area, like bowel damage or something, we may need to convert. Otherwise, almost all the appendicectomies we can approach with the laparoscopy initially. If we know already small bowel obstruction is there already because of some massive adhesions, abscess, that sort of patients, we may need to think about open appendicectomy or laparotomy for cure these conditions. Otherwise, appendix always approachable via laparoscopy. Thank you.
Next question is, what is the management of appendicular mass?
Right, good question. Appendicular mass also we discussed two types of mass. One is soft mass. Soft mass means early abscess formation and mass formation, that we can generally do the surgical management. So you can remove the early mass and we can carefully break the omentum, remove the omentum, we can do the surgery. Second thing, hard mass. Hard mass means a longer period of waiting time. Patient may be presenting you after 5 days, 6 days, 1 week, missed appendix. So that means you may need to better to wait and treat with antibiotics and offer the interval appendicectomy. That is best for the patients. Sometime they may need to undergo percutaneous drainage of the abscess. Thank you.
Next question is, do we need to do midnight appendicectomy for perforated appendicitis with or without sepsis?
Even sepsis, you don't want to rush and do in the night. No more midnight appendicectomies. Always you prefer to do in the daytime, because you have a good antibiotics now. It will cover the infection and sepsis. First, you need to resuscitate the patient, give antibiotics, and optimize the electrolytes, optimize the nutrition part and pain management, everything, and sedate the patient, inform the anesthetist, keep patient ready. Next day morning, do the surgery. That is the safety for surgeon as well as patients, because you have a good antibiotics and good monitoring facilities nowadays. Thank you. Next. Next question.
Next question is, when suspect to have appendicitis, but if the symptoms are not that prominent or severe, will the surgeon suggest medical management, or whatever the severity of appendicitis, surgery is a must?
Surgeons usually prefer surgeries. That's because this one give a long time complication like recurrence and fear of appendicitis again and again, family anxiety. Because you see, if they treated with appendix, and this appendix can happen anytime, so they cannot go for holiday for a long time. They cannot go abroad for a long time. So anytime these possibilities are there. So their parents may have anxiety about this kid, so they reluctant to take the kid for far away. Suppose if they want to go to some camping in the jungle or something, they will reluctant to send, because the appendix is still inside. Anytime they can get recurrence. So better way, finish it off the problem then and there. So after that, they don't want to worry about this appendix. So I suggest better to go even mild appendicitis. If you diagnose or think about appendicitis, better to finish it off that then and there. Don't give this option. But sometimes some patients may have bleeding disorder. Some patients may have immunocompromised disorder like malignancy or something. That sort of thing is a controversy. You can give other options also for the patients and parents. Otherwise, better to do the appendicectomy without delay. Thank you.
Then there are a few other questions, questions which we have received during the pre-survey. You have discussed most during the lecture. So one thing is that they have asked about the pain relief in pediatrics. The question is as pain relief in pediatrics. I think it's the pain relief in the
Right.
setting of
So,
pediatric after.
pediatric point of view, our main aim to relieve the pain. We have a good pain management methods in nowadays, because one thing, you see, the environment should be harmed. So they should be attracted with the environment. Pediatric kids always like the colorful things and painting and other things. So that will give first mind relax and pain, release the pain. Second thing, we can give multimodal pain approach. That means if patient is having severe pain, we can go with a high dose of, higher threshold pain management. Like we can even use morphine, we can use fentanyl, especially intranasal fentanyl is popular in foreign countries also. Intranasal fentanyl, we can apply here also. Otherwise, just ordinary pain, we can treat with the paracetamol, ibuprofen, syrups available, suppositories available. These are multimodal pain treatment we are giving. Especially treatment also one of the way pain relief, because if they have severe pain due to appendix and appendicular abscess, doing surgery also one of the way they will relieve the pain. When during the surgery time, we will give maximum dose of local anesthesia, long-acting local anesthesia like Marcaine. Buvacaine, that is very important. We will infiltrate the local anesthesia at the port site and other places. So certain hours, the patient will not have pain. But compared to adults, pediatric recovery is very quick. So very nicely, they will recover quickly. Even you can see if we do a appendicectomy, next day morning, they will play. So we will also very happy, parents also very happy, because their quick recoveries are very helpful for us also. So we are giving multimodal pain treatment nowadays, especially paracetamol, ibuprofen, that means one of the NSAIDs. And sometimes we will give some narcotics, some like morphine, short-acting fentanyl, something we can treat. Anything? Yes, thank you.
Thank you, Dr. Sayanthan. So there is very much request to do the rest of the lectures, and there are some other questions. So we'll arrange the part 2 of this pediatric emergencies in about 1 month's time.
Thank you very much. Thanks for your team. Especially, I would like to thank Dr. Samira Vijay Varthana. You are the coordinator and moderator, as well as Ms. Dinukshi, as well as Society for the Health and Research and Innovation, because you are the key people doing help. Thank you very much. Anything you can contact me also, and we can help you in the next lectures. Thanks.
Yes, our sincere thanks to Dr. Balasubramaniam Sayanthan, consultant pediatric surgeon and lecturer at the University of Jaffna, for his excellent lecture and the precious time. And it was a very informative lecture with clearly explaining the emergencies. Thank
Thank
you
you.
again.
Thank you. Thank you.
So, dear participants, please find the link in the chat box and kindly give your feedback and answer the post assessment question. And once you fill the link, you can receive the e-certificate for participation. Thank you, everyone. Let's wind up the session for today.